When a metastatic lung cancer patient walks in the door to the clinic newly diagnosed, there are several things that we need to do. So first and foremost, we need to establish what the biomarker characteristics of the tumor is. So PD-L1 is one of them, and EGFR, ALK, ROS, BRAF are the typical minimum requirements that we need to know in terms of information. So what we know is that patients who have known genetic alterations in EGFR, ALK, and ROS1, they tend to be patients who don't respond to immunotherapy up front. And so even though immunotherapy is now approved in the frontline setting, in biomarker restricted populations, these patients, even though they may meet that PD-L1 characteristic set point, they should not get immunotherapy as the first line of therapy. So they go to receive target therapy as the first line of treatment. Now, for patients who are wild type for EGFR, ALK, ROS1, the general approach is either chemoimmunotherapy or immunotherapy alone if it's PD-L1 greater than 50%. The big question is the approval for chemoimmunotherapy encompasses patients who have PD-L1 greater than 50%. And more now what we see is understanding that even in PD-L1 high patients, they don't uniformly respond to immunotherapy on its own. So how do we select patients in day-to-day practice? So generally patients who have large tumor burden, clinically symptomatic, that you need to make sure that you debulk their tumor, they need to palliate their symptoms rapidly, you're concerned that they may deteriorate rapidly. Chemoimmunotherapy is the preferred approach. Another marker that I use is neutrophil lymphocyte ratio. It's sort of an inflammatory marker. There are many studies now suggesting that the higher the neutrophil lymphocyte ratio, the chances of immunotherapy working on its own may be lower too. So I try to factor that into my decision. It's indisputable. We do see that even though, yes, there is diminishing return in terms of progression-free survival improvement or response rate improvement as you decrease the PD-L1, you still cannot ignore that there is still a substantial difference. The issue is that we need a biomarker beyond PD-L1 because there's patients with low expression of PD-L1 that respond to immunotherapy, and on the flip side, we have people with PD-L1 high expressing tumors that don't respond to immunotherapy. And one of the prime example, like I was explaining to you earlier, is the STK11 KEAP1 story that's evolving, that these tumors in fact don't respond well to immunotherapy, and they actually tend to be associated with high TMB, for example, high PD-L1, and in spite of high PD-L1, the presence of the STK11 KEAP1 mutation will trump the predictive value of PD-L1, and in those circumstances, immunotherapy alone may not work. And in fact, there is some suggestion that adding chemotherapy may not necessarily work as well. It's just that the STK11 mutation is a poor prognostic marker. These patients do have, it's a known biomarker for quite a while, associated with worse outcomes. In those patients, I will not offer immunotherapy on its own. I would certainly do something like a chemoimmunotherapy, or even a more provocative question is, would adding anti-VEGF combinations such as the Empower study setting, would that somewhat rescue the relative resistance to immunotherapy? So the jury's out there, though I'm sure those data are available to just be analyzed. So we're hoping to see more story develop in this line.